Hello, all. Welcome to this G-ScarS workshop. This afternoon, we will talk a very interesting, complex topic, which is how to prevent bad scarring. And we will focus on the two different point of view. One is biological. Do we have enough information about how to prevent a bad scarring? And the other will be more clinical and from the surgeon perspective, and the whole is skills to prevent scarring. And this is something which is still a topic of high interest for our colleagues. This workshop, as usual, is open for all of you to discuss with directly with in live with the two hyper experts we could collect this afternoon, and which are who are very famous all over the world. This world is present, and you are coming from 40 different countries. More than 200 people are registered to this webinar, so we will expect splendid exchanges. And don't hesitate to write on the chat your questions. And after around 20 minutes of presentation, we will come back and tease these speakers in order to ask the burning questions we have concerning their talk. So this workshop is supported this afternoon by the group Alliance, and we thank them for allowing us to be there all together. And don't forget that our group is organizing this year, and at the end of September, save the date, 29 and 30 of September, in the beautiful Faculty of Medicine of Montpellier, one of the oldest in the Western world. And I have the pleasure, together with Esther Middelkoop, Professor Middelkoop, Professor Ogawa, and Peter Morgat, to organize this meeting. And I hope you will be there in order to in this ambience of middle age, and to discuss with all the experts, and the list of big names in the discipline will join. Don't forget also to download, if not done, 1 million of downloads until now, this textbook on scar management all over the world, free, open access. And this is something which is a contribution of more than 40 experts coming from different point of views and different disciplines. Let's start with Fiona Wood. Professor Wood is one of the most famous experts in the world. She contributed largely to the development of tissue engineering of cells, and so she was a natural candidate to raise these questions. How can we anticipate a bad scarring with biological items? Fiona, the floor is yours. Thank you.
Thank you. Well, thank you very much. And thank you for giving me the opportunity tonight to share some of our ideas and experiences with you. I'm not sure I will be able to answer the question as posed, but hopefully I'll provoke discussion and provoke curiosity and thought, because I feel that we have an awful lot more to learn. So when we think about reducing scar risk at the macro level, we understand that inflammation is essential for healing. And that inflammation is associated with edema, and that edema in a burn context and in many other forms of injury will extend tissue necrosis and tissue loss. So I think edema control, infection control, and this rapid restoration of epithelial sealing, if you like, the sealing of the surface, will actually give us an opportunity to optimize the outcome for a given individual. But we have to understand that I come at this from a burns context. I'm a plastic and reconstructive surgeon, but I've spent most of my professional life treating burn injured patients. So I'm very much in that space. And I know that there's meticulous attention to detail at every stage in our treatment will reduce that scar. But given that, we try very hard to focus our interventions, limit the inflammation, infection, close the wounds, we will do the same protocol, same model of care on 10, 100 patients. And what we get is 10 or 100 outcomes. Forgive me for the references are very heavily referenced on the PowerPoints of the team, but I thought with me going through this very quickly and skipping around a fair bit, then at least the references and some of the references to guide further reading would be there. So the time to healing is fundamental. But look at that. It's a very scattered graph. Sometimes, with the Vancouver scar scale on the vertical axis there, even when as low as 5 days we see scarring in some people. So we have to understand there's a spectrum of response, a spectrum of activity. We have an understanding that genetics is involved, but what genes, what pathways? Again, a lot to learn at this stage. I've spent a lot of my life trying to manipulate the local environment with the evolution of cell-based therapies, manipulating the local environment to gain that seal of epithelium. As we look at starting with cultured epithelial autograft and then spraying the cells, harvesting cells at the point, developing the point of care medical device, putting the cells from ReCell with Integra. And in an animal model, we were able to see that the cells from the epidermal junction migrated through and gave us a different kind of wound. And now we work in, it's a situation that goes on as we work in developing a point of care 3D printer of the matrix as well as the cells. So manipulation of the local environment absolutely is important for scar minimization, but it cannot be addressed in isolation. And so I'd like to take a slight step sideways to explain why the origin of the thinking. And I'd like to take you to a young patient I met in 2003, in fact. He was a boy who had sustained and survived an 80% body surface area flame burn. He was treated with radical early debridement, edema control, infection control, pain management, and resuscitation, as you would expect. His reconstruction was with Integra, and then the epithelial reconstruction was with fine mesh, wide mesh with spray of cells over the top. And he survived beautifully, only to die 3 years later with a hepatocellular carcinoma with no risk factors for such a rare malignancy in a child. At the time, we were told that that was bad luck and coincidence. But really, we had to ask the question, is there a relationship between burn survival and the lifelong risk of malignancy? And could data linkage answer this question? Well, we have a body of work around data linkage where we looked at 34,000 patients requiring hospitalization for burn injury, and we compared these with 120,000 comparators from a perspective of age, sex, their geospatial. In Western Australia, it's a very large landmass, it's very complex, and so the socioeconomic factors as well were all considered. And we found that, yes, surviving a burn injury has an impact for life, and that the data was quite surprising in that 96% of the children in this database and 84% of the adults had burn injuries that were not major. I think we all have an awareness that a major burn can change your life. But in that 96% of the children, 80% of our children have no visible scar. We treat them radically, sort of aggressively early with ReCell. And so we see no macroscopic scar in over 80% of them. So what's going on here? This is a body of work that's over 40 publications. If you're interested, Janine Duke is often the first author with all the team in there. And so we started looking at all other body systems. And wherever we looked, as I say, there's a big body of work here, we found statistically significant differences in patients who had had previous burn injury that influenced their life expectancy as children as well as adults. And so we started to try and understand what is going on here and why in these children, and adults for that matter, that have no macroscopic scar, why is it in these injuries that are not major do we see a lifelong impact? And can we identify in who? Because clearly it's not everyone. We looked at IBM Watson Drug Discovery Platform. Unfortunately, this platform is not available at the moment because it's going through a significant rework. But basically, this platform had ingested 26 million abstracts, as much of the world's literature, medical literature as you can imagine at the time. And so we figured that if there was a link to be had between burns and malignancy, maybe this is a tool that could help us. During our work in this space, when you're using this technology, you have to train the tool, and training it without bias is really challenging. And so we had data from some over 600 patients where we had SCAR outcome data with genetic data and pathways data. And so we used that to train the system to see if it could change the size of the needle and the haystack. Because where do we start looking? In so many complex pathways. It changed the size of the needle and the haystack, but we're still looking. So we know that SCAR is abnormal in respect of its chemistry, the architectural framework and the mechanobiology and the cell phenotype. We absolutely know that that is abnormal. So at the beginning, what we thought before we started to really look was that the SCAR is abnormal. And that structure is tolerated by the host immune system. And what role does that changed immune surveillance have in these lifelong impacts of burn injury? And therefore, what can we use that information to identify who's going to have a poor SCAR outcome and who's going to have the lifelong sequelae of this burn injury? And then we started realizing that maybe it wasn't that so simple, because it wasn't a straight correlation, big SCAR, big burn, poor outcome. There was more nuance than that. And so looking at cellular stress and cellular senescence is another avenue we've driven down. But trying to understand the role of regeneration and not scar repair in this paradigm has proved to be very complex. Hence, I'm not sure I have the answers for you. This is just a snapshot of a pediatric cohort of patients that have had a burn injury before the age of 3. And they're a single specimen, a plasma specimen taken between the ages of 5 and 8. And you can see in the metabolic profiling, there's quite significant differences between the burns and the non-burns, I can tell you that. But within the burn cohort, which is shown here, there are the responders and the non-responders to vaccines. So what we have is a significant incidence of vaccine amnesia. This does happen from time to time. And in our control group of non-burn injured patients, there was one child that had an element of vaccine amnesia. And so why is this happening? So we've got this inflammatory response to the injury. We've got the immune response to the injury, and we can see that these are very different, and their differences are sustained. And if we can look, at the moment we've building our body of knowledge, if you like, by taking from a small pilot cohort into a much bigger biobank cohort. We're now at 300 in our biobank, in our pediatric biobank, where then we can look at this sustained change, look at the SCAR outcome, the sustained biological changes, physiological changes, and then work out using predictive analytics how we can then identify those people at the outset, and so can we adapt our treatment. But let's go back to the local area. We know that in my view, I say we know, I think we can all agree, I hope, that scarring, the scar response of an individual is a result of the local injury and the systemic response. And that drives changes. It drives changes at all levels of the skin. Certainly when I started in this space some 4 decades ago, we thought that scars were very much fibrotic, dermal, and the fibrosis was very focused on that. And so there was not a lot of uh, of of exploration those at that time into the epithelium and the underlying tissue, the systemic, etc. But we know, as is Gal Harry's work, for example, that the keratinocytes from normal skin and from keloids influence the fibroblasts differently. And we know that epithelial integrity is important and it's disrupted by inflammation. And so understanding the restoration of epithelial integrity will influence the scarring. And we've seen that in a work we've done with keloid keratinocytes that we've got dysregulation of tight junction related genes. Is this a genetic predisposition or is this a response to injury? Again, things that we need to investigate to look for therapeutic opportunities, because if we understand which pathways are involved, then those pathways can be manipulated. We also understand that the extracellular matrix with increased stiffness and those altered biophysical, physical and biological properties leads to a positive feedback, such that as the stiffer the matrix, the phenotype of the fibroblast changes to produce more collagen, which actually gives us that positive feedback loop. And the YAP signaling, and we know a lot about the different pathways involved. And we're starting to understand how we can manipulate those pathways. And certainly there's an awful lot known about TGF-beta. And we can see that if you treat normal fibroblasts with TGF-beta in the benchtop models, you could change the matrix stiffness that's produced by those fibroblasts. And so fibroblasts are very dynamic, they're very plastic. So if we can move them one way, we could be able to move them the other. So we move them down a fibrotic line, can we move them down a regenerative line? Understanding which pathways is, of course, the key. We know that the scar appearance and its pliability or loss of pliability is linked to the density of the collagen, and that's linked directly to the hydrogen bonding. The increased hydrogen bonding really starts to pull the collagen tighter and tighter and drives the basket weave into a linear and nodular appearance. And can we influence the hydrogen bonding? And this is, I just show you the next few slides of the story of some work we've been doing to try and understand the biology and then use that understanding of the biology to influence the outcome. So we started trying to understand this turnover of the scar. Clearly, the scar changes with life. A small scar on an abdomen of a child will grow as they grow. You know, we know that there's got to be turnover. So how does that relate to normal skin? So understanding that you can drink heavy water and that hydrogen will be taken up in the collagen in the extracellular matrix, which can be sampled, and then we can actually look over time how the collagen is being turned over. And so here we've got experiments we did where we're looking at drinking heavy water, serially punch biopsy, normal skin and scar skin, looking at the mass spec and seeing where is it that we see that heavy water, that heavy hydrogen, I should say, and particularly focusing on the collagen. But of course, we get a lot more information than just that, surely. But just focusing in on some of our patients who did this experiment for us, and we saw that there was a turnover of about during that 6-week period, because we did it for 6 weeks, and that the skin turned over faster than the scar. And if you were older, you turned over generally across the board, skin and scar, at a slower rate. But it gave us a guidance into, well, if we could influence this hydrogen bond restoration during the turnover, could we then change the collagen framework into a more relaxed, more regenerative kind of extracellular matrix, normal skin framework, as opposed to a thick, heavy, scarred extracellular matrix framework? And so this is our LOX inhibition, where we developed in collaboration with Pharmaxis. They have a molecule which actually does inhibit the LOX oxidase, breaking down the hydrogen bonding. And so in the animal experiment, we could see that we can actually influence the scar, both macroscopically and histologically. So at the moment, we're in our initial trials where we've demonstrated that it is absorbed topically, and then we're moving on. We've just finished the recruitment of the randomized control trial, and hopefully in the next webinar I'll be able to explain the results. But so far I'm blinded, but it does appear that some of the scars, and this is in old scars, are changing quite considerably. And I think basically looking at our scars, they are very different types, as you can see here. This is a piece of work we did using verapamil, calcium channel blocker, and we versus triamcinolone. And we demonstrated that, in fact, the verapamil was only effective in one patient. But we could have told you that if we'd looked, because we took the cells from the scars and grew them in the lab and looked at various pathway abnormalities in these cells. And the one that had calcium channel abnormalities was the one patient that responded to verapamil. I think that, it was a failed experiment on one hand, but it taught us on the other that if we can access the cells as we get the current technology, as we go into the future, we can do rapid throughput of analysis of pathway abnormalities. Then we can look at drug repurposing, etc. So there's an opportunity to really focus and target the therapies to the pathways that we find that are abnormal. But a lot of work to do. In order to do all this, we have to have we have to pay attention to other aspects that I just wanted to bring up. Things like assessment of scars, lots of ways of doing that, POSAS and all those things, really important. But also when you're really getting into the weeds, this is some work we've done with our engineering colleagues around optical coherence tomography, and so we can see birefringence of the collagen. We can see it changing before in normal skin and abnormal skin. We can also see how we can change the configuration of the vasculature in our patients where we're doing laser, but they're still abnormal. Interestingly, we see abnormalities even in those that are macroscopically normal scar. We also see changes neurologically, but that's for another time because I haven't time to go into all the neurological problems and research that we've done. I think when we look at trying to drive the biology of regeneration, we've got techniques now, single cell sequencing, epigenetics. We can diagnose a scar epigenetically. We have done a lot of work on this, looking at the epigenetic methylation profile of a keloid is very different from hypertrophic scar, very different from a normotrophic scar. Perfect technique to use for diagnosis, to be sure. And if we can change the methylation pattern, can we use that as an indicator that our therapies are being effective? And so lots of technology that is now we can use to examine the issue. And when we look at unscarring the scar, we can see the epigenetic pattern changing. And this is an old patient of mine where had been a flame burn that we resurfaced with dermabrasion and ReCell. So yes, we can unscar the scar in certain circumstances. But is regenerative healing the way of the future? What do we need to optimize outcome? There's so much I've sort of skirted over. We need to think about the source of cells capable for differentiation. Is that local to the wound or systemic migration or introduction from an external source? A framework for migration, again native to the area or introduced, as Dennis will talk about in a few moments. We need the 3D spatial information of the wound area at the cellular all the way to the neural level to drive self-organization. And then we're thinking about the nuts and bolts delivery techniques essential. How do we get the timing and understand the systemic manipulation of inflammation and immune responses to optimize outcome, and manage the fibrosis as we get the new tissue section integrated, again, both locally and systemically, because scar is absolutely more than skin deep. And holistic recovery eludes us at this point. I started 40 years ago understanding the extent of physical scarring and its relationship with psychological scarring, I thought. But there is a physiological scar that we need to interrogate to understand so that we can drive our therapeutic intervention forward. So yes, regeneration without scarring is our ultimate goal. But we need to understand the systemic impact, and a personalized medicine approach needs that personalized understanding, which means getting back to our database, multi-omics approach, predictive analytics, a lot of exciting opportunities, a rapid throughput cellular analysis for drug repurposing. All these things will give us an opportunity to change the outcome of our patients' scars in the future. There's a lot of people to acknowledge here, but this is where I live, and you're all welcome if you can face the journey to visit us in Western Australia. Thank you very much indeed.
Sorry. Fantastic talk, I said. Thank you very much. We have some questions coming from the floor. Some of them. The first one is there comparing the immune dysfunction and the diminution of vaccine reaction? I know that in Australia you were, well, a little bit apart from the catastrophes we had during the COVID period, but did you have some more information about that? Did it impact? Did burn population have a different reaction concerning vaccine and COVID? Is there any literature on that?
That's a really interesting question, and we're in the weeds of that at the moment. In Western Australia, we were locked down really seriously, and we've had problems of the isolation without the COVID. So we didn't have a lot of COVID in our space, certainly until we opened up just 12 months ago. So, but we have worked with the Phenome Centre, and a lot of the samples from Cambridge in the UK came here for analysis. What was fascinating was the long COVID patients had a profile that was really similar to the long burns, if you like. So there is something there that, yeah, and I thought it was really interesting because we started to explore some of our patient cohorts, some of our burn patient biobank cohorts with and without ventilation and respiratory problems as a comparator for the COVID, but it was clear that they were not a good comparator because they were too similar. So we're very much in the weeds of that. Then the question specifically is, do burns respond to the vaccine, for the COVID vaccines? We can't answer yet, but we're in the middle of a trial around tetanus because we have a lot of that. The other thing is we were involved in a trial where in Western Australia, 2,000 of health workers, I was number one, had a BCG vaccination plus or minus COVID. And we have photographs of all their scars. So they're being analyzed at the moment. So that's an interesting one too.
Very good. Yeah. There were other questions. I don't know if there are. Gabrielle, is there any other question? If not,
there's on the chat. Oh,
yeah. One question was you mentioned density of the scar and the capacity of proliferation. Does it means that I wouldn't like to speak about chicken and eggs, but what if I formulate my question, if you take care about the scar with integrating a strong mechanical containment of this car, does it work? Because this is, Ray Ogawa's mantra concerning mechanical approach and physical and mechanical. So, what is your opinion on that?
I think that's a really interesting question, because I think it certainly has a place, but I think it can't, not in isolation, because if we can hold firm, then we have to change something. So we can reduce scarring, certainly in surgical incisions, by negative pressure, I think, because that changes both the edema and the pressure and the tension across the scar. So I think there's certainly the mechanobiology there is really important. But when you've got an established scar, you've got to change something then, whether you're doing it with laser with microthermal zones, whether we do it with LOX inhibition, whether we're doing it systemically or locally. There's got to be something else going on that will actually facilitate that change in the mechanobiology to become established. So I think we have to look at this as it's a complex, sort of almost like a Rubik's cube. And what we're trying to do is trying to get how many things do we have to have on one color on one side for us to then allow the scar to fade away. And so I think it is interesting, but I think we need to test things in combination, not as individual things, modalities.
Okay, another question. Which age ranges are at particular risk from hypertrophic scarring?
I think that again is a question that we're investigating at the moment, because sort of historically we felt that the very young are okay, the sort of the few month-old babies, then we get a little bit of a peak, and then we get a peak around teenage. It certainly falls away as people age, and we've done a piece of work looking at the genetics of aging and scarring, and that's again, scratched the surface, but has not really given us any concrete direction with respect to pathway manipulation. And looking at once I've stood back from this, I thought, does the clot that is forming change with age? And so we've just got a grant to look at that. And so we're looking at with our biobank specimens, with the scar outcome, with clinical data, and then we're looking at the mechanobiology of clots in the blood at different ages. Because if that framework, that initial framework is different, is that the trigger? So that was just a hypothesis we had that we're chasing down related to that question.
And there is another question, which is if you speaking about pediatric burns, one question is compliance of pediatric population, and the second is how do you deal with that in terms of opting for a more medical management or a more surgical scar management, saying we cannot do something now, but we will choose something later. Is this something which is balancing in or did you find the right angle to approach this problem?
When I first started, and with using cultured epithelial autograft and then rapidly going to cultured cells in suspension, I realized that if we were in a position, we started using it for big burns. But when you look at the pediatric scald injuries, the dermis isn't denatured in the same way as it is in a flame burn. So could we salvage that dermis by spraying cells on the surface? And so very quickly, by the mid-1990s, we were spraying cells on children using a very small donor site, the size of a postage stamp, a very light dermabrasion of the burn wound, spraying it and sealing it. And so we get 80% of those kids have no visible scar. And our indigenous children are the right color. We've reduced the hyperpigmentation, and we've reduced the hyperpigmentation incidence in our donor sites as well. And so that's the base of which we came from. So a lot of our patients don't need the scar management. And then we get those that we have to skin graft. We often skin graft and spray over. They all start scar management, and we have a very involved education, learning management package for the parents, for the kids, for our staff as well. So we're all talking the same language. And certainly even in an environment where it's very hot here, especially in the Northwest, we've adapted fabrics as well. We've researched different fabrics for our pressure garments and that kind of thing to make them more acceptable. So we do get a reasonable compliance, but more recently, we've introduced the laser, and we would lose laser at 3 months for anybody who's looking like they're going to get a scar in the pediatrics. So we're aggressive. We treat early, we treat surgically, and the vast majority then don't need anything else. But with the ones that are starting to develop, we treat early again, and we treat with laser. And if we get color mismatch, then we will come back and do more resell, because the resell can get the right color.
Mm-hmm. And just the last question. When you say surgically aggressive, does it mean that the dermal matrices is in your armamentarium included, highly used, or do you think that keeping the natural dermis of the children is enough? What is your position? Changing or keeping the?
If I have pediatric scald injury, we will, even a big one, we will really drive to salvage that dermis, because the native dermis is something we can't replace, really. But if in the flame and the deep burn in the flame, we use the dermal matrices, and have done since 1994. So we first used Integra in 94, and then with the mesh and spray as a secondary. So when I say we're surgically aggressive, we're aggressive with respect to time, but then our focus is on salvage of the wound and a low risk surface, which is the resell. And then we would anything that's deeper, then we put a mesh and spray. But if it's a flame burn, then we'll be in that space where we're considering dermal matrices. Yeah.
I have two more questions. One from our old friend Kenneth Dolinchuk from. So, what is the effect on collagen type and content in burns following scar treatment? Regenerative response is a future benefit we all agree with.
The effect of collagen type in terms of the dermal scaffold, I presume, because certainly, yeah, I think one of the things that we're increasingly looking at in the punch biopsies that we have of this, the LOX inhibition work, we're staining the different collagens, but the vast majority is you've got the dermal epidermal junction, you've got the dermis. I'm not sure that we should be driving different collagen types. Maybe we should be driving a more elastin, in the extracellular matrix.
Thank you very much. And another question from Mohammad Shais Khan, who says, kindly comment on role of immunosuppression to prevent scarring in burns, and also steroidal versus silicone. So many questions.
I think immunosuppression is really hard because we know that infection is such a problem. And what's been interesting is we've just presented some work that we at our ANSBAR meeting last year, where the adults with the poorest scar outcome had less inflammation early, but it was dragging on, and those that healed well had a higher peak of inflammation and then it fell. So the area under the curve from an inflammatory perspective was less, but in the delayed inflammation that was chronically high, their healing was delayed and they had a poorer outcome. And those were the ones that had a secondary compromised immune response. And so I'm not sure that we should be driving immune suppression, because I think that doesn't really, doesn't really make sense. In that context, I think immune manipulation, I think, is a different thing. And so if you look at how you're going to influence your immune system's response to these injuries, you're going to do it by inflammation. And we need inflammation to heal. So we need the inflammation at the right time, at the right level, and then drop it. And so I think that will influence the immune responses rather than targeting the immune system itself. But maybe I'm wrong.
No. Well, the last comment is coming from Jocelyn Kopp. Frames, please. What is early inflammation versus slower? So this is. Can you put the question on the screen, please? Thank you.
Right. So when you look at, you measure all the cytokines, etc., the early inflammation within the first 24 to 48 hours, and we measure the area under the curve. Yeah.
Professor Wood, we know that in Western Australia it's close to 11 p.m., so we allow you to go to bed, and we thank you so much for this fantastic question and answers, and see you soon, and in Montpellier, I hope.
Yes, I hope so soon. It's nice to be able to see people again. Thank you.
Thank you. So our next speaker is another monument in scarring, and he will answer the same question, which is how to prevent bad scarring, with another approach, which is the surgical approach. And it's our honor and pleasure to introduce to our group Professor Dennis Orgill, that all of you know. And Dennis will give his presentation, which is already pre-registered, and he will come with us at the end for questions and answers. So welcome to Dennis, and please start his registered video.
Good afternoon. It's a pleasure to be with you today. I'm Dennis Orgill. I'm the medical director of the Brigham and Women's Hospital Wound Care Center, and I work at Harvard Medical School. Today, I'm going to talk to you about a 50-year journey that's happened in skin substitutes. Started back in 1970s and continues through today. And there have been a lot of innovations in this field. I happened to start when there were just concepts being developed, and I was at MIT. And there are three technologies that came out of MIT, which are basically the foundation for everything we do today. So you can, and we'll talk about different technologies that came out of there. And I was mostly involved with the dermal substitutes, so I'll talk a little more about that because I know more about it. But I was peripherally watching the other two technologies evolve. Skin is a very complex organ, and a lot of people just think of it as a protection from bacteria and water, but it has a lot more than that. It's tough. It protects us from the environment, from breaking down. We know that without a skin barrier, infection is a problem. So it has important immunological functions. It has blood flow and thermal regulatory functions. And so when this is lost, it can be a big problem. Now, back in the 70s, ICU care had improved so that we could take someone with a large burn that was over 50% of their body and we could actually keep them alive. And one of the problems that people were running into back then is that we didn't have enough skin grafts to cover those areas. And so these people would languish for a long time in the ICU and they would heal either with horrible contractures or infections. So as a result, there was a real need for these skin replacement technologies, and the National Institute of Health in our country, along with some defense money, supported these efforts. And there were three separate efforts at MIT all going on at the same time, which I'll talk about. Skin provides really the first line immunity for us. It's under constant surveillance. It's looking at things, and we know that transplanting skin is one of the most immunological areas of the body. And interestingly enough, Joe Murray, who did the first kidney transplant, was a plastic surgeon, and the reason why he went to kidneys is because he felt skin was too difficult of a problem to transplant at that time. Loss of skin, we very often treat with skin grafts. Here's an example of what a skin graft looks like. Many of you do these all the time and you're very well familiar, but for those that don't, these can often be taken with a device called a dermatome, and that leaves a scar which heals up usually in 2 to 3 weeks. And you can see what the scar looks like. This will become more, will fade over time, but still leaves a scar where we take this from. So when we think about reconstituting skin, some people think, well, you just need to replace the epidermis because we just need to keep free of bacteria. Other people felt that dermis was the most important thing because dermis is really where we generate scar tissue. And then a third group really felt that you needed both of these. And so these were the three basic concepts going by in the 70s. And here I am when shortly after I moved to Boston from California, and I ended up in Dr. Yanasa's lab making these things. We'd actually make them in the lab. We tested them on animals. When they got good enough, we would actually make them and transport them over across the Charles River to Dr. Burke, who was at the Mass General and the Shriners Burns Institute. This is Howard Green and Jim Reinwald. They were close by in the biology department, and they were really the first ones that were able to culture skin cells, the epidermis, in large amounts. And they figured out how to do this, growing these on a irradiated 3T3 mouse fibroblast layer. And this was a big conceptual advance in tissue engineering, being the first ones to do that. And they were able to get a multi-layered epidermis that cornified at the end, and they developed the methods to do this. So this has the advantages that you can take from a very small skin biopsy and expand this out. The disadvantage is it takes 3 to 4 weeks to do this, and it's a very labor-intensive, high-cost method to replace skin. Gene Bell, who was right down the hall from Howard Green at MIT, also in the biology department, talked about something of the skin equivalent, which had both epidermis and dermis. like structures. The dermis came from fibroblasts, the epidermis from keratinocytes, and he developed this. This actually ended up not working well in burn patients, but has subsequently found to work well in chronic wounds as an allograft, not an autograft. So someone else's cells would be useful. And then this is Dr. Yanas, who I work with. He really felt that the scarring was a major problem in burns, as directed by Dr. Burke, who was his clinical collaborator, and was able to develop these biodegradable scaffolds that would degrade at about the same rate as the body would synthesize new tissue, and they would form a new dermal-like substance. The So it was bilayer, this collagen gag below, and then a silicone layer above, which was designed to simulate the water loss that normal skin would have. And the advantage of this was that it would be an off-the-shelf product. It would promote dermal regeneration. It was quite a bit less costly. The disadvantage is that it takes a while for this process to happen. It does require a skin graft at the end, although the skin graft can be quite thin, as I'll show you. And it is a little more sensitive to infection. All these products are actually fairly, you have to use them in a fairly clean setting to make them work. And here's Dr. Yanas with pictures of the scaffolds and how these work. And here's a timeline, which we showed here, where starting back in the 1970s, of a whole family of these scaffolds was designed, and these were tested both in vitro and in animals before we moved on to humans. And then at some point, this needed to be translated to a commercial entity. So Marion Laboratories in Kansas City started off with it and built the manufacturing facility and did the clinical trial. And then Integra Life Sciences actually was a startup company that took this over and has now developed into a multi-billion-dollar company, selling not only this, but many other products. So even though we're sort of 50 years into this, we're still finding new applications and learning much more about these scaffolds. Here's MIT on the upper left, and our lab was just to the left of the dome over here. And we would make this and take it over to the Shriners and the Mass General, which is about a mile away across the river. I spent a number of years there and got two theses out of working on these areas. So I'm going to talk about some concepts today, which are regeneration, self-assembly, cell shape, remodeling, and translation to humans. I'll talk on a variety of scales going from the molecular to the macro and all along the way. The first concept is regeneration. Most people think that humans heal only by scarring, and that's only partially true. We know that in lower animals, such as a salamander, if you cut off a limb, it'll totally regenerate. That really doesn't happen in humans, but it may be that the regenerative response is blocked by scarring. We also in humans have an area that's where people overheal and get things like keloids and scars, which Dr. Teo and others will talk more about. Duncan did this very important study in 2005 where he took on normal human volunteers. He made a cut of variable thickness, and what he found was that below 0.56 millimeters there was no scar. So about a third of the dermis you can cut through and it will heal without a scar. Cell shape is also very important. Cells tend to grow on scaffolds or matrices, and they spread out as integrin receptors from the cell bind to these surfaces. Cells that divide tend to proliferate when they're spread out, and cells that are spherical tend to go into programmed cell death or apoptosis. And so for us as plastic surgeons that want to generate new tissue, we basically have three levers that we can pull. One is soluble growth factors, which we're all familiar with. The second is how we design these extracellular matrix, and the third is mechanical forces. And you can see here, this is nonlinear optical microscopy that Dr. Yanas did. You can see how these cells spread out over time and are not totally spherical when they're in contact with a variety of scaffolds. Judah Folkman and Don Ingber, who were at our institution, really pioneered the area of cell shape. And Don's talked about the area of tensegrity. And they're really the ones that talk to me about cell shape and how that is important for us. The original design of the product, which is now called Integra, which was 2 layers. The bottom layer is a collagen glycosaminoglycan highly porous scaffold, and the top layer is silicone. This is how it's made. You take today bovine Achilles tendon, swell this with acetic acid at pH 3, add chondroitin 6 sulfate to form a coprecipitate, lyophilize this to form a highly porous solid, and then add cross-linking and silicone to get to the product. You can see what decellularized skin looks like on the left and what the scaffold looks like on the right, many similarities. And we optimize this in a guinea pig model, which would heal by primarily wound contraction. We can block that contraction by placing the full thickness skin wound on, and the thought was that if we could at least partially block it with a scaffold, that would help our scar. Interestingly enough, it takes longer to heal with our scaffolds than it does leaving an open wound, but as you'll see later, it provides a better scar. So if we look at this, we can see that there are areas of alpha smooth muscle actin in the open wound above. These are all lined up and contract, whereas in the scaffold, they go in different directions and pull in different directions, hence less bringing the wound together or contraction. And so there's a whole bunch of things like buckling theory that we need to go through. Dr. Burke first started with this with the abdomen, and here's where he used 2 pieces. You can see the seam here, and here this is 5 years later. Around it is meshed autograft. You can see this looks a lot better than this. These are 2 areas where he lost a little bit of the silicone, and you can see the scar here. So these areas still persisted as scar, but the main part looked very good. The surgeons liked it, the patients liked it, and that gave us a lot of encouragement to move on. We also went and did this in peripheral nerve to show that these scaffolds are very useful in other things, and scaffolds are being used in many different tissues today. We can seed these with cells, and with seeding them with cells through centrifugation, we were able to totally regenerate both the epidermis and dermis in under 2 weeks. And you can see that the cells don't necessarily get exactly where they need to go, but they will get to the right location over time. It remodels as this is degraded and forms a dermis. We optimize this by the guinea pig model, and we optimize a lot of things such as the porosity and the cross-link density and many things in the scaffold through this model. When we seed it with cells, we get basement membranes form. The cells aren't exactly in the right place, but the body's smart enough to figure out where they go, and it naturally separates out the dermis and the epidermis. A new basement membrane gets formed, and capillary loops form in the pseudo-reedy ridges. This is how it's formed today with the collagen from bovine Achilles tendon, which is ground up, and this process, which is in Plainsboro, New Jersey, they have these giant freeze dryers. These trays are exactly the same size as what we use at MIT, and because of the regulation involved, to change even something like a tray size makes a big difference. So when you're developing something new, just realize that things that you do may last for a very long time. So these were the design principles. We wanted to get around the scar, which formed from burns, and regenerate the dermis. And why collagen? Well, it's non-toxic. In Europe, people are a little scared of it because of the BSE issue, but that's never been an issue for us. It's the principal protein in the skin. It's easily supplied. GAG, there are several of them that we could have used. We chose chondroitin 6 sulfate because it handled well, worked well in our processing, and was relatively inexpensive. And so the translation, I'm just going to go through some cases here. Here's a woman who had melanoma, who we excised and placed this on, waited for the margins to be cleared, and then at about 3 weeks, we took off the top layer of silicone, took a very thin skin graft from her clavicular area, which healed with minimal scarring, and put this on. And you could see, other than a very minor contour defect, it's hard to tell if she had anything done there. So I've used a lot of this in facial reconstruction. And here's another woman who had a marginal ulcer on her head. It's nice. We ended up with positive margins. We're able to go back, get the margins cleared, and here she is. And she survived radiation therapy. Not everybody does well with radiation, but some people can. And then we can do little things like this, where an ear has a basal cell cancer can be removed. Typically, we'd use a posterior auricular flap, but we can put this on and just allow it to heal. And here he is a year later. You can barely tell he had anything done there. And we can do these on noses. Noses are a little more challenging because of the complexity of the skin. And here's a woman who had her dog bit her nose off. She's actually a junior in high school who showed up on the day before Christmas, and really a devastating injury. Some people would use a forehead flap, but that's pretty deforming in a young woman like this. And so we cleaned it up as best we could and put this product both inside and outside the nose, and saw her back, and over time trimmed back the silicone, allowed it to heal, and then revised it. And she got a pretty good result without having to use her forehead. We've used it for some weird things. Here's a guy who had cardiac surgery who ended up having pyoderma gangrenosa. So we took him back, debrided it, put on Integra over the wires. You can see the wires that are exposed, and we just let that on, and over many weeks let this heal up, and it actually covered up the wires, and we didn't have to do anything else for his sternum. So I've learned a lot over the time. Sometimes when we try and design things that help us, we go for something that's really super complicated. I think going for things that are simple and work is great. Now with the internet, it's easy to collaborate with anybody in the world. And I work with people from all over the globe, and it's really fun to have people that are interested in the same thing that you are work. And the other thing I've learned is treasure the unexpected. Like when we first got our animal results back showing that the wound didn't contract, didn't close as much with our scaffolds. People were worried about that, but it turned out to be a good thing, not a bad thing. And then have fun with the process. These take a lot longer than you think. So if you enjoy the process and what's learned, it can be really fulfilling. So we have some challenges moving forward, and I hope that some of you will take these on. We still have room to improve scarring. We still want to do surgery that's less invasive, and we'd like to minimize our donor sites. So I'll stop there and look forward to taking any questions you have. Thank you.
Thank you very much, Dennis. It was a fantastic talk. I think we have some questions from the floor. Thank you to have the opportunity to spend some minutes with us. We know that you're absolutely overbooked, but we will try to be concise. Well, two questions. One is, you evoke scaffolds which are non-cellularized, like Integra or well, others. Um, uh, but you have a donocyte problem. A donocyte. What is your opinion on these new products coming, integrating a minimal donocyte and a culture of cells on different types of scaffold, including fibroblasts and keratinocytes? Did you test them?
Yeah, I mean, obviously we've tested a lot of this stuff in animals, but it hasn't. It's only starting to get in humans, and there are some of these products now that I think you're involved in some of the clinical trials as we are with other products that combine cells with some sort of scaffold. And I think time will tell how effective these are. My guess is that these new products will be effective in smaller wounds, but if we try and expand them too much, they may not work as well. But that's just my guess. We'll have to see.
We have a question from Muhammad Shais Khan. What is the best time to excise full thickness burn and apply Integra, and when to proceed with grafting?
So, I think that's a complicated question and depends on the clinical things. But when we've done it in burns, we've tried to do our excisions early and graft early. If you wait, then the risk of infection goes up. So earlier is generally better, but you have to have a center that will be able to support that. So I think it's center dependent.
Thank you. Another question that you evoked in your clinical cases, which is pyoderma gangrenosum. We have, well, as you certainly have, dermatologists taking care of that and advising not to do any surgery on that. But it seems that some of in US, you and other colleagues are promoting a more surgical excision and applying dermal substitute plus skin grafting, which changes completely the profile of the disease. What is your do you have a long series of pyoderma gangrenosum surgically managed?
There's one other case which we published. You can look it up in PRS. We work with our dermatologists closely, so they'll immunosuppress them, and then we'll do the excision and placement of the scaffold, and then we try not to do the skin grafting and just let it heal, and secondarily, like we did with the sternum, and you can see you can get quite big wounds to heal that way. In the case that we published, we did use a skin graft, but we got clearance from our dermatologist that they felt that the inflammatory phase had resolved. And so it's a way that these wounds, as you know, hurt a lot. And so it provides a way to minimize the pain, get them closed without a huge donor site. So we clearly need more people to try this and report their results. But if it works as it has in the couple of cases we've done, it may have some great potential.
Last question from Sonali Uchil. Will Integra help in chronic wound ulcer over exposed tendon Achilles?
Yeah, that's a great question. I think for small areas of exposure, it will. My experience with most Achilles tendon things and chronic ulcers is I will bring them into my office and I will do office debridements until I get down to a granular base, and then very often with the VAC. Sometimes I'll use Integra, but sometimes I can get it to granulate with the VAC so that a skin graft will work. Sometimes I can't, and we'll use a free flap. But I think if you have a whole Achilles tendon and put an Integra over it, it's probably not enough blood supply to support it.
Okay, I think we've done, and I know that you have a lot of things to do. So
well, thank you for making this just ended up being an interview day for us. So really appreciate you putting this together and including me.
Thank you very much, Dennis, for your time and splendid talk. Thank you.
Thank you so much. Bye-bye.
Bye-bye. So thank you for all of you. You stayed till the end of this workshop, and it's fantastic to have you interacting with good questions. So I wish you a beautiful day and or night, depending, and see you next time for the next workshop. Don't forget, save the date again on Montpellier University Scar Club at the end of September, and hope to see you soon. Bye-bye.